Assalamu alaikum. The third lecture in temporary pacemaker in ICU. Today we will discuss transcutaneous pacemaker, its indication, its advantage, disadvantage, and complication. Cutaneous pacing, it differs tool twitching and potential cardiac depolarization. May produce small rectangular burns and it's typically short-term solution. It can be used in patient as emergency for bradycardia due to heart block, so patient not responding to medical management, or overriding pacing, or pacing in the pre-hospital environment. We should instruct the patient before using a transcutaneous pacemaker. If the patient is conscious and oriented, we should warn him about the twitches and the discomfort will happen, and to let him to understand that they will apply transcutaneous beds. And before insertion, we should do trimming for the hair instead of shaving, as sometimes shaving would cause some abrasions in the skin or some lesions, so it will hurt the patient and causing some more pain, agonizing pain for the patient. Anatomy and bed placement. Anteroposterior placement is ideal. Conductive gel bed should be placed with one on anterior chest and the other on the back. Another side is apex V5, and the right parasternal V1 placement is a less effective alternative for the patient. Note that negative or plaque electrode should be placed at the apex and the position of the other bed between the scapula. This placement is the ideal one, and it will improve the chances for capture. The upper part of the photo, the ideal placement, which is one anteroposterior in the anteroposterior one anteriorly at the apex, and the posterior one between the two scapula posteriorly. And the second part in the photo is the one and right parasternal V1, and the second at VF at VF at the site of VF electrode. Inserting the beds, we will change the defibrillator to pacer mode like that, and the current at that time will be 0 milliampere, increasing gradually till it achieve capture. And if the patient is conscious, so it will be comfort with this current, and the rate will be 70 beat per minute, or increasing the rate based on the patient underlying rate. We will adjust the defibrillator. First, as I mentioned before, we will attach the pads to the defibrillator, connected these pads to defibrillator. Then we choosing pacing mode, and which mode, VVI or VOO. We will choose VVI because it's better to avoid RONC. The rate should be set at rate 80 to 90 beats per minute. The dosage depending on patient position. If the patient is unconscious pre-arrest, we can use the minimum current. The default current is 140 to 200 milliampere. And if the patient is conscious, we can use the lowest current, increasing gradually to 5 to 10 milliampere till we have maximizing the comfort, and the patient will not have any annoying or disturbance from and disturbing pain from this defibrillator. Dose of electricity for transcutaneous pacing. Pace the myocardium merely needs to depolarize a small amount of tissue and from where the action potential will spread normally. The current required, therefore, much smaller, as the impedance will be stable between beats and pulse duration is fixed, and only will need to 20 to 40 milliamperes. If we compare it with the external defibrillator, which is confused to some fact, which the defibrillator needs joules for energy, however, the pacing needs current ampere per current. And the main reason for this is the difference between defibrillation and pacing is the key. For defibrillation, we need effectively to deliver amount of current needs to depolarize a critical mass of myocardium at the same time. So we will give 2 joules in biphasic, 200 joules in biphasic, and 300 joules for monophasic. And we should notice that there is some loss of the energy till in the surrounding structure in the muscle of the chest and around the in the bones before it reached to the heart. The advantage of transcutaneous pacemaker is widely available, non-invasive, require minimal skill to implement it, improvement over ineffective medical or conservative therapy, usually only temporary measure. The disadvantage, it requires skill to troubleshoot. Uncomfortable, requires sedation, sometimes pain for the patient, especially if the patient is conscious, can cause burn if we use high amperes, especially in obese patient. Sometimes ineffective despite bed position and changes because the patient may have a sweat, maybe with the changing the position of the patient, the bed get loose and not well fixed. Not sustainable long-term solution. It's a need to be changed to transvenous, for example. Indication if there is existing chest wall burn, presence of wounds or dressing, if there is any contraindication to sedation, especially if we have a problem regarding the airways, relative contraindication in patients who are morbid obese, so we need to put maximum output to capture the patient, maybe annoying the patient with the pain, burn, so it's not a good solution for morbid obese patient. The complication, burns, pain, and consequence of the sedation, skin reaction to electrode gel, skin tears due to adhesive pads on a fragile skin, obscuring radiographic finding while the bed are in the position. Sometimes we need to see the underlying chest condition in X-ray. It will not appear. This is an X-ray for how the basing gel bed appear in the X-ray. It's in the anterior position and the other one in the back of the patient. So the part of the lung will be hid by the gel bed. If we use the one at V1 and the other at V5, so there will be hiding of the lung behind the gel bed and the underlying position for anterior lobe and the part of the lung from the other part will be hid and the pathology will be hidden from hidden by the bed. What is the safe duration for transcutaneous pacing? Transcutaneous pacing has been used continuously for as long as 5 to 4 days. It's recommended to check the back every 4 to 6 hours. Regular basis, not left it because with the time it will lose its capture. Maybe in some cases we need to change the bed even 4 to 6 hours. Sometimes in some reports, medical reports, they recommended that there is a burn after 12 to 36 hours of pacing. We need to know how the pacing capture. It's very important to have two important diagnoses. You are not in need to staring at the monitor all the time, and we should know pacing artifact is usually narrow and solitary like this. But if we have proper captured QRS complex, so there is a spike, and this is wide QRS complex, it will resemble left bundle branch block morphology, and will be wide and followed. Every spike will be followed by QRS complex. So this is mean proper capture of the pacemaker. The reference of this lecture, you can use it, and thank you for following the lecture, and you can post your questions and comment down in the comment.